Hi, I'm Jan Marie Graham. I'm a nursing instructor at University of Calgary in Qatar, and I'm presenting this poster on behalf of myself and Lisa Moralejo, who's a co-instructor here. The poster came into being because we had written a number of standardized patient scenarios for our psych rotation and wanted to share the wealth of those scenarios with the world. So we've done standardized patients in mental health for the last 4 years and found it to be a very powerful learning tool. So I'm hoping to give you a glimmer of some of what goes on in that process through the poster. So we're doing this because we believe, and the literature would bear out the fact that standardized patients and use of simulation in psychiatry, mental health, nursing actually is a powerful learning tool and provides a filler for the gap between theory and practice. So it allows our students, most of whom are second English language learners, to practice asking some of the difficult questions. It allows us to help them structure questions and ask questions that in the cultural context normally wouldn't be acceptable or easy to ask. So things like, are you thinking of killing yourself? Have you ever been sexually abused? Are not things that come into casual conversation in any culture, but even more so in our Arab Muslim context. So the other thing it does is it provides a safe environment to practice. And what we do is we have them practice, 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 because we do it twice during the term, once at the beginning before they get to clinical, and once in the middle where we see vast improvement. And it allows them to practice opening, it allows them to practice closing, asking the questions, how they create a therapeutic environment, strategies and ways to redirect or do their therapeutic communication skills. So it's a very rich learning, and it's always a lot of fun. So you sneak a lot of learning into a fun environment. Beautiful thing. It's situated learning, so there's two students, and we pair them deliberately. We pair them usually stronger, weaker, and in terms of language, but also in terms of theory and practice, so it's a deliberate process. We have a standardized patient who's actually a trained actor, and they're trained by our simulation standardized patient coordinator, who's a wonderful thing to have. And then an instructor who acts as instructor observer. So the instructor is set apart, but still in the same room as the patient, standardized patient, and the teacher, or pardon me, the students. So we model real life. We don't interject unless they're totally off the wall, but for the most part, the learning comes within the interview from each other, so the collaboration, and then after it's done, we do a debriefing. And the standardized patient usually starts with something like, oh, you guys did really well, it was really good, you introduced yourself, but you didn't talk about confidentiality, or you didn't make much eye contact, or I didn't really understand that question, or when I said this, you laughed and that upset me. So there's lots of real-time, real-life feedback. And then the students talk about how they felt about things, why they asked questions, how they could rephrase questions. And then the instructor also contributes to that collaborative learning at the end. So I've talked a little bit about that's taken you through the procedure. Findings, just to wrap it up, the students always want to do more. They really enjoy it. They think it's positive learning. It demystifies some of the difficulties that they perceive they'll have that they really don't have once they get into the interview setting. When we did a bit of a survey to ask them whether they thought it was positive or not, they said that yes, it did help them do a mental health assessment. They all said it made them more comfortable asking general questions for a mental health assessment. More importantly, it made them more comfortable asking some of the difficult questions that I talked about earlier. And then the best part, I think, is that it reduced the fear they have of what for many of them is an unknown entity. Again, because there's more stigma here around mental health. So all that they know, or all they think they know about mental health patients with mental health illnesses, is what they see on TV, which we all know is usually wrong. So why we continue to do this here at UCQ? It's effective, it increases their comfort level, it increases their confidence. It models a collaborative learning and teaching strategy, which is what we want them to do as nurses once they get out and practice. So it models the way we see a team working. It increases their communication skills as well. It bridges the gap between theory and practice. It gives them immediate responsive feedback, so it's fresh in their minds. They can reflect on it. It's always a positive experience, even if it's not something that they've thought about before. They can take it, and you'll see them integrate it through the day. When they start with interview 1, you can see them get better in interview 2, 3, and 4. So it's a very, very good learning tool. The other thing, again, because we're in a second language environment, and I nor my colleagues speak Arabic, it allows us to actually do the evaluation piece. So we can't sit in and observe a real therapeutic relationship or interview on the ward, but we get to see it in the clinical area. So if you're teaching in the psych mental health field, I recommend the strategy and wish you good luck. Thank you.